Imagine this, right? Got this beautiful horse, seems perfectly healthy, but then you notice these strange tiny bruises, maybe on its gums,
Mm.
or it gets a nosebleed and it won't stop. What could possibly be going on there? Well, welcome to the deep dive. This is where we take all the source material you send us, research papers, articles, notes, and we dig in. We pull out the most important bits, the key insights, basically give you a shortcut to getting really up to speed. And today we are diving deep into some really fascinating stuff you sent about a condition called equine thrombocytopenia. Our mission to unpack what this all means, for understanding the health of horses. We'll look at what it actually is, uncover a pretty surprising fact about horse physiology, explore why a horse's platelet count might suddenly drop, and of course, how vets figure it out and treat it. We'll even touch on prevention, what the future might look like. So whether you own a horse, you're studying vet med, or maybe you're just fascinated by biology, this deep dive should give you some real aha moments. Let's get into it. So first things first.
When we talk about thrombocytopenia in horses, what are we actually defining? What's the number?
Right. So for horses, we define thrombocytopenia as when their peripheral platelet count, platelets are also called thrombocytes, drops below 100,000 per microliter of blood. That's generally the threshold.
Okay, 100,000. Now, you mentioned something, or rather, I found something in the sources that was really surprising about horse platelet count specifically, something that makes them different.
Yeah, that's a super important point. Unlike a lot of other mammals, horses naturally have one of the lowest normal platelet counts among domestic animals.
Really? Lower than you'd expect.
Definitely. Their typical adult range is pretty wide, maybe 90,000 up to 350,000 per microliter. Foals are usually a bit higher, over 200,000.
Wow, so 90,000 could be totally normal for a horse.
Exactly. What might look like moderate thrombocytopenia in, say, a dog could be absolutely fine in a horse.
So that species difference is huge for diagnosis then.
Crucial. Vets have to use equine-specific reference ranges. Otherwise, you risk misdiagnosing a healthy horse.
That's a massive takeaway right there. Okay, so let's talk about these platelets, these tiny things. What exactly are they?
They're fascinating, actually. Platelets are tiny anucleate fragments, meaning they don't have a nucleus like other cells. They come from these really big cells in the bone marrow called megakaryocytes.
Okay.
They're the smallest cellular bits floating around in the blood, and they don't last long, maybe 3 to 5 days in circulation.
And everyone knows they're for clotting, right? Like little Band-Aids.
That's their main claim to fame, for sure. They kick off blood clotting, that's primary hemostasis, forming the initial platelet plug. And they help with secondary hemostasis, too, the whole clotting factor cascade.
But the sources suggested their job is, well, bigger than just stopping bleeding.
Oh, absolutely. It goes way beyond just clotting. Platelets are actually deeply involved in other things, like inflammation, the body's response to injury or infection. They're also key for tissue remodeling, helping repair damage. And they even play a role in innate immunity, that first line of defense against bugs.
Huh. So they're multitaskers.
Definitely. Which means if you don't have enough of them, the effects can be much broader than just, bleeding risk. It can impact the whole system.
Right, that makes sense. So if these tiny giants are so important, what are the signs? What do you actually see when a horse's count drops too low?
Well, it really depends on how low the count gets. If it's just low to moderate thrombocytopenia, say between 30,000 and 90,000, you might honestly not see much. Maybe no clinical signs at all.
Really? Nothing?
Often, yeah. Unless there's some other problem with their clotting system at the same time.
So it can be kind of hidden until it gets worse.
Yeah.
When does the obvious bleeding start?
Generally overt bleeding, the kind you'd really notice, that typically only shows up when the count drops below 30,000 per microliter.
Okay, below 30,000.
Yeah, then you can start seeing spontaneous bleeding. But, horses vary. Some might not bleed much, even down at 10,000. It's weird.
Mm-hmm.
And here's another key thing. A horse going through trauma or surgery, they can bleed significantly even with counts that aren't that low, maybe below 50,000.
So a seemingly okay horse could still be a risk during a procedure.
Exactly. It's something vets have to be really aware of.
So what are those visible signs then? The things owners or vets should look out for?
The classic signs are things like petechiae. Those are tiny, pinpoint little red spots, hemorrhages, and ecchymoses, which are larger bruises.
Where would you see those typically?
Good question. Mucous membranes are the easiest place. Check the gums, the whites of the eyes, the conjunctiva, inside the nostrils, vaginal membranes. Also, non-pigmented skin, like on the belly.
Okay.
You might also see actual bleeding from orifices, like epistaxis, that's a nosebleed. Hematuria is blood in the urine, or melena, which is dark, Tory stool from bleeding in the gut.
And I guess just bleeding longer than usual?
Yeah, prolonged or just excessive bleeding after something minor, like getting blood drawn or after surgery. That's a big red flag. And sometimes just general lethargy can be a sign too, especially if it's severe.
It sounds like you really need to be suspicious, even with subtle signs, because the obvious stuff only happens when it's pretty bad.
That's exactly right. Early detection relies on a high index of suspicion.
So, okay, a vet suspects it. What's the next step? How does the diagnostic detective work begin?
It always starts with the basics, getting a really thorough history from their owner, what's been going on, any changes, and then a meticulous physical exam, looking specifically for those signs we just talked about, lethargy, petechiae, any bruising or bleeding.
Right, and then lab work. Now, I read in the materials that just using the automated machines for blood counts can be tricky with horses.
Yes, absolutely. That's a critical point. Automated hematology analyzers can sometimes give misleadingly low platelet counts in horses. It's called pseudo-thrombocytopenia.
Pseudo, like false low.
Exactly. It happens because horse platelets can clump together easily in the sample tube, or sometimes the machine mistakes little bits of cell debris for platelets or doesn't count the clumps correctly.
Ah, okay, so the machine gets fooled.
Pretty much. Which is why a manual look at a blood smear under the microscope is strongly, unequivocally recommended. It's the primary way to confirm if the count is truly low.
So someone actually has to look with their own eyes.
Yes. In a healthy horse smear, you'd expect to see, on average, maybe 6 to 10 platelets per high-power field under the microscope. It's essential to tell a real low count from just a machine artifact.
Got it. That's super important. So beyond just confirming the number, what else can looking at that smear tell the vet?
Oh, the smear gives you a ton of clues. For instance, if you see really large platelets, sometimes called stress platelets,
Right.
that usually means the bone marrow is working hard, trying to pump out more platelets to compensate for loss elsewhere in the body. It's regenerating.
And what if you see broken bits?
Right. Platelet fragments can suggest that the platelets are being destroyed, maybe by the immune system. And sometimes you might actually see infectious agents, little bugs or inclusions inside the blood cells pointing directly to an infection.
Wow. Okay, so the smear tells you about number and potentially why it might be low. But clotting is more than just platelets, right? What about the rest of the system?
You need the whole picture. So a comprehensive coagulation profile test that look at the overall clotting ability is vital.
Like PT and APTT.
Exactly. Now, in straightforward immune-mediated thrombocytopenia, or IMT, those tests, PT and APTT, are usually normal. The main clotting pathways are okay.
But not always.
Right. In really serious conditions like DIC disseminated intravascular coagulation, where the whole clotting system goes haywire.
That sounds bad.
It is. It's basically widespread, uncontrolled clotting throughout the body. In those cases, you'll see other changes, like high D-dimer levels, which are breakdown products of clots, and low levels of antithrombin, or AT, which normally helps prevent clotting. Those tell you the system is being overwhelmed.
And you mentioned DIC in horses often involve clots forming, more than just bleeding.
Yes, that's a key point for horses. While bleeding can happen, the thrombotic phenotype, meaning the formation of dangerous microclots that damage organs, often dominates in equine DIC. It's a very severe complication, often triggered by things like sepsis or endotoxemia.
Okay, so differentiating an isolated platelet issue from something systemic like DIC is crucial. What about checking the source, the platelet factory itself, the bone marrow?
Yeah, sometimes you need to go right to the source. A bone marrow evaluation, either aspirating some liquid marrow or taking a small core biopsy, can be really informative.
What does that tell you?
Well, if you see fewer megakaryocytes, those are the big precursor cells that make platelets.
Right.
That points to a production problem. The factory isn't making enough. But if you see normal or even increased numbers of megakaryocytes, it suggests the factory is working fine, maybe even over time.
So the problem is happening after the platelets leave the marrow.
Exactly. It suggests they're being lost or destroyed out in the circulation.
Okay, so you've done the smear, the coagulation test, maybe the bone marrow.
Yeah.
What other advanced tools help pinpoint the specific cause?
Then you get into more targeted tests, specific serologic testing, for instance, to look for antibodies against infectious agents like equine infectious anemia virus, EIAV, or other viruses, bacteria, protozoa. We also use molecular tests like PCR that can detect the DNA of microbes, which is helpful for diagnosing bacterial sepsis, or even things like Clostridium tetani.
And what about imaging? Can you see anything with X-rays or ultrasound?
Definitely. Imaging is indispensable sometimes. Ultrasound, X-rays, even CT or MRI can help find underlying issues, maybe hidden internal bleeding, tumors, structural problems that could be contributing.
And biopsies of other tissues too.
Yeah, sometimes biopsies of other organs like the liver, spleen, or intestines might be needed if you suspect a systemic disease like, say, lymphosarcoma, a type of cancer.
Wow, it's really like being a detective putting all these clues together. So let's talk about the main suspects. What are the big categories of why a horse's platelet count would drop?
Broadly speaking, there are four main mechanisms, although, like we said, it's often a mix or multifactorial. You've got decreased production, increased destruction, increased consumption, and sequestration.
Okay, let's unpack those. Decreased production, that's the bone marrow factory problem again.
Right. This can happen due to primary bone marrow failure, like aplastic anemia where it just stops making cells,
Right.
or something called myelophysis.
Myelophysis.
Myelophysis, yeah. It's when the normal marrow gets crowded out by abnormal stuff, like cancer cells and leukemia or lymphoma. Typically, white cells drop first, then platelets, then red cells. That sequence can be a clue.
Can drugs cause this too?
Oh, absolutely. Certain drugs, estrogen, some antibiotics, chemo drugs, even radiation can suppress the bone marrow. The good news there is the counts often recover if you stop the drug. And some infections, like EIAV, can directly attack those megakaryocyte precursor cells in the marrow.
Okay, so that's production failure. What about increased destruction? The platelets are being made, but then they're getting destroyed too fast.
Correct. The big one here is immune-mediated thrombocytopenia, IMT. That's when the horse's own immune system mistakenly targets and eliminates its platelets.
Why would it do that?
Sometimes we don't know that's primary or idiopathic IMT. Other times it's secondary, triggered by something else, like drugs, infections, tick-borne diseases are a common trigger, or even cancer. Immune complexes, like those formed with EIAV, can also stick to platelets and mark them for destruction.
So infections can cause destruction directly
Right.
or trigger the immune system to do it.
Exactly. EIAV is a classic example, often causing cycles of low platelets. Anaplasma, babesia, other infectious agents can do it too, often immune-mediated. And vasculitis inflammation of blood vessels can also lead to platelet destruction. That can be triggered by bacteria like Strep equi, causing purpura hemorrhagica, or viruses like EIAV again.
Okay, that covers destruction. Then there's increased consumption. They're just getting used up too fast.
You got it. And the prime example here is DIC, that disseminated intravascular coagulation we talked about.
The out-of-control clotting.
Right. It's a devastating syndrome. The body starts forming tiny clots everywhere, and that process just chews through platelets and clotting factors at an incredible rate, triggered usually by sepsis or endotoxemia. Also, simple massive blood loss, like from a major trauma or surgery, can cause a temporary drop in platelets just because so many are used to try and stop the bleeding.
Makes sense. And the last one was sequestration, like they're being held hostage somewhere.
Kinda, yeah. It means pooling. The spleen normally holds a reserve of platelets, maybe 30–50% of the body's total. If the spleen gets enlarged, that splenomegaly, it can just sequester or hold on to a much larger portion, leading to lower counts in circulation.
So they're not destroyed, just stuck in the spleen.
Pretty much. And endotoxemia can also cause temporary sequestration, with platelets getting stuck in tiny blood vessels, especially in the lungs.
It's clearly complex, often multiple things happening, or sometimes you just can't find the cause, right? That idiopathic diagnosis.
Exactly. It's often multifactorial, or sometimes, despite all the tests, we end up with idiopathic thrombocytopenia, which is basically a diagnosis made by ruling everything else out.
So, okay, you've done the detective work, maybe found a cause, maybe not. How do you actually treat it? What's the path to recovery?
The absolute cornerstone, the most critical thing, is to identify and treat the primary underlying cause. Whatever is driving the low platelets, you have to address that.
Symptomatic treatment isn't enough on its own.
Right. It might help temporarily, but it won't fix the problem long term if the underlying issue persists.
Okay, so let's say it is immune-mediated IMT. What's the approach there?
For IMT, the goal is to stop the immune system from attacking the platelets. So immunosuppressive therapy is the first step. Usually that means corticosteroids like dexamethasone or prednisolone.
How do they work?
They basically dampen down the immune response, blocking that destruction. But, and this is important, they need to be tapered off really slowly, often over months.
Why so slow?
To avoid side effects, things like increased appetite, drinking, urinating more, higher infection risk, and also, crucially, to prevent the condition from relapsing as soon as you stop the meds.
Are there other options if steroids don't work or cause too many problems?
Yes, for cases that are refractory, meaning they don't respond well, or if side effects are bad, vets might use other immunosuppressive drugs like azathioprine or sometimes vincristine.
Okay. And beyond those specific drugs for IMT, what about general supportive care? Things that help any horse with low platelets.
Supportive care is absolutely vital no matter the cause. Number one is rest. Strict rest and activity restriction are paramount to reduce the risk of bleeding, either spontaneous or from minor bumps.
Makes sense. What about transfusions? Do you give platelet transfusions?
While blood transfusions are mainly used if the horse is severely anemic because of blood loss, the goal there is to get red blood cells in to carry oxygen. We usually use whole blood.
So not specifically for the platelets.
Not primarily, no. The thing is, platelets in stored refrigerated blood don't survive well. They get inactivated. Even if you use fresh, unrefrigerated blood, the lifespan of those transfused platelets in the recipient is really short hours to maybe a day or two.
Okay. So it's not a lasting fix for the platelet count itself.
Generally not. Now, platelet-rich plasma, PRP, that's different. Vets use that sometimes. But usually for localized therapy, like injecting it into an injured tendon, not really for raising the systemic platelet count in thrombocytopenia.
Got it. What other supportive things are key?
Fluid therapy is often crucial, especially if the horse is dehydrated or in shock from blood loss. Getting fluids in helps restore blood volume and correct electrolyte imbalances. And if there's an infection, like sepsis, then appropriate antimicrobial therapy is essential. You might start with broad-spectrum antibiotics and then adjust based on culture results.
And managing pain, I imagine.
Hugely important for welfare. We might use NSAIDs like bute or banamine, but very carefully.
Why careful?
Because they have a narrow safety margin, especially if the horse is dehydrated, they can cause stomach ulcers or kidney problems. So caution is needed. Corticosteroids can also help with pain and inflammation. Sometimes muscle relaxants or even opioids for severe pain. And just keeping the horse calm and comfortable in its environment helps too.
And for those really scary complications like DIC, any specific treatments?
Yes, for DIC, heparin is often used. It's an anticoagulant.
Wait, you give an anticoagulant when they might be bleeding?
It sounds counterintuitive, right? But remember, in equine DIC, the big danger is often the excessive clotting damaging organs. So heparin, either the standard unfractionated type or low molecular weight versions, can help reduce that dangerous microclot formation. It's considered pretty effective and safe in horses for that purpose.
Okay, that makes sense in that context. Are there any, cutting-edge regenerative therapies involved?
Sometimes, yeah. Things like platelet-rich plasma, mesenchymal stem cells, bone marrow aspirate concentrate, IRAT therapy. These are generally used more to help heal tissues that might have been damaged by bleeding or inflammation associated with the underlying condition, or for other concurrent problems like joint issues. They aren't usually direct treatments for the low platelet count itself, but more for supporting overall recovery and healing.
Right, so looking at the bigger picture, what's the general outlook? What's the prognosis for a horse with thrombocytopenia, and how do you prevent it?
The prognosis is honestly highly variable. It really depends on the underlying cause.
Makes sense.
If it's something like a bone marrow cancer or active EIA or widespread neoplasia, the prognosis is often grave, unfortunately. But if it's, say, drug-induced or secondary to an infection that you can clear up, the prognosis can be much better once you remove that trigger. The severity of the low platelet count itself and whether the horse develops serious complications like DIC or major hemorrhage also plays a big role in the outcome.
And managing them long-term, what does that involve?
It requires really diligent monitoring. Serial platelet counts are key, maybe daily at first, then weekly as things improve. Constant observation for any signs of bleeding or other illness. And if the horse is on immunosuppressants like steroids, that careful, slow weaning process under vet supervision is absolutely critical. Plus, managing any other chronic underlying conditions is vital.
Okay, so for owners, what about prevention? Are there things you could do to stop this from happening in the first place?
Prevention really focuses on managing the risk factors for the known causes. Equine infectious anemia, EIA, is a big one to highlight.
Because it causes those cycles of low platelets.
Exactly, and it's a lifelong infection with no cure. So prevention is everything. That means regular testing, the Coggins test, isolating or, sadly, sometimes euthanizing positive horses to prevent spread, controlling biting flies, which transmit the virus, and strict hygiene with needles and syringes. Never, ever reuse them between horses.
And there's no vaccine for EIA, right?
Correct. No vaccine. So biosecurity and testing are key.
What about other preventable causes?
Tetanus is another important one. While it doesn't directly cause thrombocytopenia typically, it's a serious related infectious risk. Thankfully, it's very preventable with the tetanus toxoid vaccine that's a core vaccine every horse should have. And using tetanus antitoxin for immediate protection if an unvaccinated horse gets a wound is important, along with good wound care.
Any general advice?
Just general good husbandry and vet care. Using drugs judiciously, avoiding unnecessary meds that might suppress bone marrow, and being proactive about diagnosing and managing any chronic inflammatory conditions or potential cancers early on can help reduce the risk of secondary thrombocytopenia developing.
Well, we've certainly covered a lot of ground. We've gone from, a surprisingly low normal platelet count in horses through all that complex diagnostic work, the different causes, and the treatment strategies. It really highlights how interconnected everything is in a horse's body, doesn't it? Hopefully you listening now have a much clearer picture of why this one tiny type of blood cell is so incredibly important for a horse's overall health. So here's a final thought to leave you with. We've seen how this tiny component, the platelet, impacts everything from basic clotting right through to inflammation and immunity in horses. What does this deep dive tell us about the sort of hidden complexities and the unique ways different species adapt? How might understanding these specific details in horses maybe broaden our whole perspective on health and disease across the entire animal kingdom, maybe even including ourselves? Something to ponder.